Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
In minimally invasive surgery, doctors use a variety of techniques to operate with less damage to the body than with open surgery. Now, in general, minimally invasive surgery is associated with less pain,
Good.
shorter hospital stay,
Very good.
and most important, fewer complications.
Yes, here to talk about minimally invasive chest surgery and using 3D printing for complex chest procedures is Mayo Clinic thoracic surgeon, that's chest surgeon.
That's right. Good. You said it perfectly.
Dr. Shanda Blackmon, welcome back to the program.
Thank you so much. It's great to be back.
Dr. Blackmon, nice to have you. So let's talk about minimally invasive surgery as it relates to the chest. What does that mean?
So traditionally, when we do chest surgery, and when I trained to do chest surgery as a resident, we would make an incision on the back underneath your shoulder blade or in the front of the chest, and we would cut all of the muscle on the way in. Usually the muscle is called the serratus muscle or the latissimus muscle. For those of you that are professional swimmers, those are the muscles you use to do the butterfly. And then we would put a crank in between the ribs and slowly turn the crank and spread the ribs, cutting all the muscle.
Are you going to faint?
So as you can imagine, that generated quite a bit of pain.
Cracking the chest.
Yes. So the crank compresses the nerve, which sits right underneath that rib. And whenever you put some kind of pressure in between there, it results in significant pain and something that we call post-thoracotomy pain syndrome. So we thought about how we could possibly make it less painful, and I flew all over the country and started trying to learn these techniques from other surgeons that were pioneering that field and brought them back and practiced and worked hard to try to find a way to make it less painful for patients. And so now we can do almost every surgery we do today with 1, 2, or 3 tiny little ports the size of my finger going into the chest with instruments, and then we just make one little incision underneath the ribs where we can slide a tumor out that might be big, so we don't have to spread the ribs to take these large tumors out, and it's much less painful.
And how do you see what you're doing?
We put a camera inside the chest and we put a breathing tube in, just like we do for open surgery, that allows us to collapse one lung and ventilate the other lung.
And so you collapse the lung that you're operating on?
Correct.
And what are you taking out most often?
Usually a tumor in the lung or a tumor in the front of the chest called like a thymic tumor. Sometimes we'll take out tumors from the esophagus that way.
So you can't, if you have to pull this tumor out between the ribs, it can't be a very big tumor, can it?
Well, the lung is very squishy, and once you get the air out of it, it can usually come out of a small 3-centimeter incision without a lot of rib spreading. So we can't get a whole lobe out from that space, but if it's a big lobe or a big tumor, that's when we make these small accessory incisions underneath the ribs in what we call the subxiphoid space to pull them out so we don't have to spread the ribs.
And xiphoid is the bottom of your breastbone.
The bottom of your breastbone, so it comes out kind of underneath that space.
This whole conversation, the last 3 minutes, has made me very uncomfortable.
Are you a little queasy?
Well, it's just a lot. I mean, I know you have used the phrase cracking the chest before and, pulling the ribs open and twerk, just like on your spine, that has to be terrible.
Yeah.
And now I just can't imagine the difference that it must make for the recovery of the patients to not have to endure that.
Yeah, it's amazing. You can almost go on rounds the next day and identify who had an open chest surgery and who had minimally invasive surgery without examining anyone's chest. Most of the patients that have these kinds of surgeries go home in 1 or 2 days, sometimes 3 days, depending on the big size of the surgery. That what's done on the inside is the same. It's just what's done on the way in that's different.
Okay, so it takes a couple of days if you have this minimally invasive surgery. What is the recovery if you do not?
Usually a week.
Oh,
yeah.
A week in the hospital. So there's an
epidural for pain control.
Epidural meaning an injection adjacent to the spine to help with pain control.
Correct.
But isn't it good there's such a thing as general anesthesia, Tracy?
It sure
the
is.
patients are asleep when you
Well,
I know, but
that's
a lot to recover from.
Yeah, so there are some places in China and in other parts outside the United States where they're doing this surgery on patients when they're spontaneously breathing without a breathing tube in, and sometimes just under monitored anesthesia. Now, we aren't quite that brave. I think if we had an emergency, it would be really hard to get, the patient fully asleep with a breathing tube in, but there are some really brave patients volunteering for that kind of surgery.
So is this surgery called VATS, video-assisted thoracoscopic surgery?
Correct. And now the same approach can be used for robotic surgery. Robot versus thoracoscopic or inside the chest with a camera, that's for both VATS and robot. A patient would wake up and wouldn't know the difference of whether or not they had a robot surgery or a camera surgery, a thoracoscopic surgery. The only difference is in the instrumentation. The port size is pretty much the same. With a robot, sometimes you end up with more ports than a regular minimally invasive chest surgery. But the real benefits are, that you have less pain, typically less blood loss, easier breathing because your chest wall isn't hurting, so maybe slightly less pneumonia. And a really interesting study that was published out of Duke showed that patients actually made it to their chemotherapy quicker and more often because they weren't debilitated from the surgery. And there are even some long-term studies that are coming out that are saying there might be a survival advantage because of the inflammation that comes from having a big chest surgery versus a less invasive chest surgery.
So is it true that when you're doing the VATS surgery, you're right there next to the patient, but when you're doing robotic surgery, you're over at a console controlling the instruments?
Yeah, you could be in a different hospital, but most of us couldn't tolerate that.
Now, you talked about pneumonia, so as a complication, and I'm sure there are complications, even with VATS surgery, minimally invasive surgery, robotic surgery. What are some other complications that you've seen?
Well, you can have a thoracic duct, which drains the fat from the belly up into the chest, leak, and it has a milky substance that leaks into the chest. You can have air leaking from the lung, which is the most common complication that we see. You can have pain from any kind of surgery. So just because it's minimally invasive doesn't mean that you won't have pain from it. And then you could have bleeding. Because there's small holes, I think there's a lower chance of bleeding. But if the work on the inside is the same, you can bleed from that area as well. So those are most of the complications that we see.
I would just, to go back to the comparing of the two, it would seem to me that opening the chest would make it easier for the surgeon to do whatever you have to do in that surgery. Is it harder to do a minimally invasive surgery?
So have you heard of the law of energy? It's neither created nor destroyed. So in surgery, we have the law of pain. The pain amount stays the same. For open surgery, the pain is on the patient. And for minimally invasive surgery, the pain is on the surgeon. So it is harder. It's sometimes the technical parts of doing the surgery are more difficult, and that's why we think robotic surgery might be helpful sometimes for surgeons that had a really hard time learning how to do it minimally invasively. The robot sometimes helps people who weren't very good with VATS become better with minimally invasive surgery because it's more like open surgery.
So were you able to practice in the cadaver lab, or how did you learn how to do it?
So there's a woman who's very key to teaching VATS surgery named Sherry Meyerson, who developed a model. And then we 3D printed a chest wall cage, and we created this model where you could go in and practice as many times as you want. And you would have an artificial lung that you would operate on, or a lung that's much like the one in a human that you would operate on, and you would practice doing these procedures. And I used to teach these courses all the time. Now it's part of our curriculum. So most thoracic surgeons who are coming out of training, it's part of their required training. And so we don't have to teach so many classes anymore because most people now know how to do this.
How long do the procedures take? Does the VATS procedure take longer than an open procedure, or are they about the same?
I think it's about the same, maybe even quicker, because you don't have to sew the chest back together.
Yeah. Well, the resident does that anyway, don't they?
Oh, no, not in my room.
So you mentioned the fact that you can remove tumors from the lung. What else can you do with VATS surgery, minimally invasive surgery in the chest?
So you can cut the sympathetic chain. So if somebody has sweaty palms, we call that hyperhidrosis. You can cut that and get rid of the sweaty palms or sweaty armpits. You can take out tumors from the lung. You can take out tumors from the front of the chest. There's a surgeon named Don Jaruzelski who practices at Mayo Clinic in Arizona, who does a minimally invasive approach to fix the pectus deformity where the chest caves in.
The breastbone is caved in.
The breastbone is caved in, and she can pull it back out and make it look like a normal chest. She's really like the world's expert in that area.
Wow.
We can take out and rebuild parts of the esophagus. We can do pretty much anything inside. We can even take a clip off the left atrium of the heart if someone has a big left atrium and atrial fibrillation to keep them from developing a clot in that part of the heart.
Pretty amazing, huh? Minimally invasive chest surgery. We're talking with chest surgeon Dr. Shanda Blackmon. We'll take a short break. When we come back, we're going to learn about using 3D printing to help with complex chest surgeries. Time for a short break. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with chest surgeon Dr. Shanda Blackmon. We've learned about minimally invasive chest surgery, and now we want to ask Dr. Blackmon about 3D printing, what it is and how you're able to use it for complex procedures.
So 3D printing is a fascinating new concept in surgery and medicine, but it's really an old concept that's been out for a long time. 3D printing is basically where you use some type of anatomic model, a three-dimensional model that's created on the computer. And then you use these things like little tiny triangles that come up together to create a particular type of file called an STL file that's exported from the computer to a printer. And it's just like a laser jet printer. It lays down a layer, and then depending on the type of printer, that layer becomes a solid piece. There are support structures and there are printed structures that will be the model that get printed. And then the next layer goes on top, and then the next layer goes on top until you have this sort of building type structure. And then you put it in a washing machine that washes off the support material, and you end up with this model. It can either be made of solid plastic, it can be made out of titanium if you have enough money to buy a titanium printer. It can be made out of some type of a solidified powder or some type of, clear plastic thing. And you can print soft things and you can print hard things. So you can imagine the possibilities are limitless.
So how does that, so you actually have a model of the patient you're going to operate on with the abnormality included?
Yeah, and the great thing about it is it's printed life size. So you can practice the surgery the day before you do it. Most of our surgeons that use 3D printing ask for the model several days in advance so that we can show it to the patient, educate the patient. I mean, patients look at a CAT scan and their head just starts swimming. They don't know how to read a CAT scan, and we're trying to point things out that look very clear to us because we've been looking at CAT scans our whole lives.
It's hard to see the 3D aspect of that.
Right. And your brain is meant to interpret 3D images. So when you show a patient a 3D model of whatever is wrong with them, they immediately understand it, and they start to comprehend how you're going to fix them and what you're going to do, and it all starts to make sense. So it makes our job easier, especially when someone doesn't have normal anatomy. So if you're born with some kind of thing that's different from the normal body, it helps the surgeon because your body is different from the average human, and we need to know how are we going to approach it differently based on that new thing. Either a prior surgery made you different, or you were born to have a slightly different anatomic part of your body. So it helps us to get a leg up and familiarize ourselves before the case.
How do you decide if you want a 3D printing of a patient? Obviously, you can't do it on every patient and don't need to.
Yeah. So the way that I decide is if I have more than 2 surgeon groups in the operating room, communication has to be perfect. Planning has to be perfect. It's usually a complex case if we've got 2 teams coming in. So if I have a neurosurgeon coming in, or if I have an orthopedic surgeon coming in, or another vascular surgeon coming in, and we're all working together, that 3D model helps us to understand and plan, all right, I'm going to go here, and then you're going to go there, and then we're going to work together in this area. This part we're going to have to take out and rebuild. This part, it's just like having a model of a car you're going to take apart and rebuild the day before you take apart and rebuild it.
It's practice.
It's like cheating.
For the patient's perspective, practice makes perfect. So
Exactly.
How many times, I'm sure for some of these, you could practice multiple times.
Yeah, you can. And the thing that I've noticed is with 3D printing, initially I was a bit of a skeptic and I thought, well, is this really going to be practice changing? I'm not really sure. But once we started 3D printing some of our superior sulcus tumors, I thought, well, I do minimally invasive surgery for regular lung tumors. Why couldn't we do it for this? So we've actually invented brand new surgical procedures because we've been able to have time to think about the model, look at the model, practice angles, look at different techniques and approaches, and be a little bit more thoughtful about the way that we minimize the impact on the patient, minimize the incisions. So now we do minimally invasive Pancoast tumor resection sometimes.
Pancoast meaning a tumor.
Is the tumor at the top of the chest. Or we've been able to do, we had a patient that had a lot of prior surgery before he came here. They had taken out most of the ribs in his left chest, and his arteries were rearranged inside his chest. He was a very complex patient. We basically wanted to take out part of his esophagus because it was leaking inside his chest. We went into the stomach, through his feeding tube, backwards, upside down, into the esophagus, and removed the esophagus backwards and upside down, inside out.
You
Did
said,
you understand that?
I did. Well, you said earlier that the human brain is meant to understand 3D.
Yeah.
It would make sense then that it has transformed your practice, because if you can look at a 3D model, it would help you figure out and invent new ways to help in your surgical practice.
Yeah. So I think, 3D modeling helps with patient education. It helps with coming up with novel approaches to a tumor that might be more complex and not something commonly done. It helps with taking care of patients who've had a lot of prior surgery, and it helps the surgeons to innovate.
So do you actually take this model into the room with the patient and say, here you are, and
Yes.
here's your tumor, and here's what we're going to do?
Yes, and the patient tries to tuck it into their purse and take it home with them. They love these models. They want to keep them.
Paperweight, the coolest paperweight ever.
So what's the biggest tumor you and your colleagues have removed from the chest or the chest wall?
Well, that would probably be 8 to 10 pound synovial sarcoma that we removed from a young woman who had a novel treatment here at Mayo Clinic a couple of years ago. She was a very young woman, and we came up with a multi-team approach. It was a large tumor about the weight and size of a small baby inside her left chest. And ironically, that same patient got married on the steps of Plumber.
Oh, awesome.
But you guys got it out.
Yeah, of course we got it out. And then she got married.
Of course.
Chest surgeon Dr. Shanda Blackmon, minimally invasive chest surgery. It causes less damage to normal tissues, less pain, a shorter hospital stay, and less complications. And we have just learned about life-size 3D printed models, which are a huge help to surgeons in doing complex chest procedures.
Amazing.
Pretty amazing. Dr. Shanda Blackmon, thanks for joining us.
Thank you.